Right. Hello everyone, I'm Jillian Dann. I'm a PGY2 solid organ transplant pharmacy resident at University of Virginia, and I'll be presenting a technician talk today on solid organ transplant pharmacy concepts. I have no actual or potential conflicts of interest to disclose, but I will be discussing off-label use of medications during this presentation. The nature of transplant medications is that many of them have not been studied for the indications that we use them, so we often use medications off-label. My objectives for this talk today are to describe the most common etiologies for transplant and the listing process that transplant candidates go through. I'd also like to summarize the immune system concepts relevant to solid organ transplant and review the transplant medication classes, the indications for use, and some important considerations for storage, handling, and preparation of these medications. So first, why do patients need transplants? The most common indication for kidney transplant would be, of course, kidney failure. So these are patients whose kidneys have failed and are on dialysis. The most common reason for kidney failure is hypertension and diabetes. There are many other causes of kidney failure, but those are both the most common in the United States. Liver transplant has common indications of hepatitis C, alcoholic cirrhosis, and autoimmune hepatitis. Pancreas transplant is most commonly done for the indication of type 1 diabetes in patients who have had insulin requirements since a young age and have found that it's very difficult to control their blood sugar with their insulin. Less commonly, pancreatic transplant can be done for type 2 diabetes, but like I said, type 1 is the most common. For lung transplant, the most common indications are chronic obstructive pulmonary disease, or COPD, or also known as emphysema, idiopathic pulmonary fibrosis, or cystic fibrosis. Heart transplant is most commonly performed for patients who have cardiomyopathy, either due to non-ischemic or ischemic causes. So this could be something like a heart attack that has left their heart very much weakened and unable to pump sufficient amounts of blood to the body. So what is the transplant surgery process like, and what leads up to the process of actually getting the transplant? So a patient would be followed by an outside physician covering their or caring for them for the condition for which we're transplanting. This physician would refer the patient to a transplant center, and UVA is one transplant center in the country. Once they've been evaluated, once they've been referred, they're very thoroughly evaluated by our transplant team. It's a multidisciplinary team that investigates the patient's physical and mental health to make sure that they are a strong candidate for transplant and would survive the surgery and benefit from the surgery in the long run. We also make sure that the patient has an adequate support system. Once they leave the hospital, that's not the end of their journey. That's really only the beginning of the transplant journey. They'll have to take medications daily, twice daily. They'll have to return to the hospital for follow-up visits, and that will require some support from family and friends. We also make sure that the patient has adequate insurance coverage, as transplant is a costly operation. The medications that are required afterwards are also costly, and complications are possible, like with any other surgery. We evaluate their nutritional status, and a nutritionist makes recommendations to optimize their nutrition prior to transplant so that they have the best chance of having the best quality of life after. And as a pharmacist, the main thing that I'm evaluating prior to transplant would be a patient's ability to take their medications as prescribed post-transplant, and also to assess for any drug interactions that are present and would be known prior to transplant, and try to address those if necessary. For example, sometimes we have to switch patients' medications to avoid interactions with some of the post-transplant medications. I also assess allergies and make recommendations for perioperative management of these patients. So a common allergy would be a penicillin allergy, and penicillin allergy would definitely not be a reason that we can't transplant someone, but we would have to take that into account when selecting perioperative antibiotics, for example. So once the patient has gone through an extensive evaluation, they can then be listed for transplant. So at that point, the patient is placed on a wait list and then they wait for organ offers. The organization that controls the wait list is UNOS. It's a national organization that that receives organ donor information and matches that with individuals on the wait list to ensure a good match between the donor and the recipient. Some of the things that they're taking into account for that match would be blood type, size of patient, and there are a number of others, but that's just a brief list. For kidney and liver patients, we can also look for living donors who are well matched to our patient. So this could be a family member or a friend who, like I said, has a blood type that's compatible and is size compatible, among the other things that we look for, who is willing to donate to this individual. Or we can do what we call paired exchanges, where you may have heard of these on the news. One person is not a match for their family member, but they're a match for someone else who's also requiring a transplant, and there's kind of a domino effect. One person gives to their friend, another person gives to a different person's friend, and we can do a paired exchange, as it's called. At the point that an organ is identified that is appropriate for the recipient, the patient is then called in for transplant. So the patient must be available for transplant. They have to stay within a certain radius of UVA, and that's part of the requirement that is placed on them when they're listed. They have to be available because the organ could become available at any time, and the organ is not, it has a shelf life, if you will. It has to be implanted within a certain period of time, so they have to be close to the center. So if the donor organ is accepted by our center and the recipient is available, then the donor is procured from the donor organ is procured and it's transported to UVA. Sometimes it's flown in or driven depending on where it's coming from. And then the transplant can occur. So to give you an idea of what is actually happening in a transplant and where exactly we're putting these organs, I think this is really interesting, so I thought I would share it with you. In the case of kidney transplant, we actually leave the native kidneys, so that the person's original kidneys in place, and then add the additional kidney down lower in the abdomen. So it actually sits in the front of the abdomen and is connected to the bladder using existing vessels to connect it to the bladder, and then the blood supply is brought in off of a different blood vessels from where your normal kidneys sit in the body. So, and this is done for both living donor, which is what's shown here, so this would be your donor giving the kidney to the recipient, or for living liver or deceased liver donation as well. So in this case, this would be a living donor where half of the liver is removed from the donor and it's placed in the recipient. And if it is a deceased donor, it can be the full liver that's done, or it can be a split liver case, which is what's shown in this image. For heart and lung and pancreas transplant, it's a similar concept, but the original organ is removed, similar to the liver transplant situation, and the donor organs are placed within the recipient in the same place where the original organs were. Okay. So how many transplants are performed at University of Virginia? We are a center that is growing, and in 2017 I have the numbers listed here for the number of transplants that occurred. So you can see we did about 137 kidney transplants, and I have the breakdown of deceased versus living donors. So 96 deceased donor cases and 41 living donor cases. Our kidney program is our most active program, and since the initiation of kidney transplant at University of Virginia in the late 80s, we've done almost 2,100 kidney transplants. Our other programs are less active, but still pretty active. We performed 71 liver transplants at University of Virginia last year, 24 lung transplants, 16 heart transplants, 4 kidney pancreas transplants, which is when a patient receives both a kidney and a pancreas at the same time, and 2 pancreas alone transplants. As I mentioned, our transplant program has really been growing within the past few years, so you can only expect these numbers to increase and the number of transplant medications dispensed by the pharmacy to increase as well. So why do transplant recipients require these immunosuppressive medications? I'd like to take a few minutes to go over some basics of the immune system. I won't dive too deeply into it, but it's important to understand why these medications are required after a transplant. The immune system has two broad groups of cells that have two kind of big functions. The first is surveillance. So these cells are always watching out for either a foreign substance such as bacteria or fungal infection, or they can also be watching out for your donor organ. They recognize the donor organ as non-self and therefore determine that a tactical attack function is required. So this would be our other function of the immune system. And the group of cells that performs the tactical attack function, if you will, is receiving the signal that there is some foreign object and that it should be eliminated from the body. In this case, it's our donor organ, and we do not want it to be attacked by our immune system, so we need to reduce the function of the immune system in order to protect the organ. So, as I've mentioned, the functions of the immune system are pretty broad, and I'll summarize them now. The immune system functions to recognize and protect against infection by infection-causing organisms. So this could be bacteria, virus, or fungus. It also recognizes and destroys cells with mutations. For example, cancer cells that have mutations occurring, the immune system can recognize and help to eliminate or slow down the division of those cells. The immune system also causes cell injury and destruction, which creates inflammation within your body. The inflammation sends signals which recruits more immune response to that area. So once several cells have been destroyed, then more immune response occurs and more cells can be destroyed. So how does this recognition of a foreign object occur? Our bodies, as well as all different cells that are in the body, produce proteins which are expressed or kind of sit like flags on the edge of the cell, and they identify the cell as self, or it's recognized otherwise as non-self if it's a different kind of flag. Once a non-self molecule has been identified, then signaling molecules are released, which recruit inflammation to the site. This is done by a number of different cells. The cells specifically are not important, but I would like to just point out the broad groups for our future discussion of the medications and how they act on the immune system. So the first would be your innate immunity. These are the cells that you are born with and function by recognizing those non-self proteins to create an immune response. The second is adaptive immunity. These are the cells that learn over time that something is not self and that they need to defend against it. I'd like to give an example of how your body does this in a way that I think we'd all be familiar with. So in the case of vaccinations, a vaccination is administered, which is usually a small amount of protein from a virus, such as the flu. The body forms an immune response to this virus when it's given in a small amount as a vaccination, and then it forms a memory of that, which is stored in the B cells. The B cells are your main memory kind of function. And if your body is exposed for a second time to the virus, so for example you've been exposed to the flu, it's able to mount a quick response to the virus when it's seen for a second time. So now I'd like to ask just a few questions regarding the material that we've covered so far to assess your understanding. University of Virginia performed approximately 250 transplants in 2017. Please select the statement that is true about the transplant process. A. Transplant patients are first seen at UVA by physicians at the time of transplant. B. Transplant patients are usually healthy prior to transplant with few medical conditions. Or C. Transplant patients undergo thorough evaluation prior to transplant by the multidisciplinary team. So the correct answer here is C. Transplant patients undergo extensive evaluation prior to transplant by a multidisciplinary team. They are definitely not seen by physicians for the first time at UVA at the time of transplant. We know them very well by the time they get to transplant. And transplant patients are determined to be healthy enough to survive surgery, but they definitely have medical conditions prior to transplant. This would be end-stage kidney disease, liver disease, lung disease, or heart disease. The indication for their transplant would be a disease. And for my second question, the immune system has multiple different types of cells. Which of the following is involved in the immune system's memory of infection and allows for a quick response to infection if a second exposure occurs? A, the innate immune system cells, B, the T cell line, or C, the B cell line? And the answer to this question is also C. It's the B cell line. These function as your memory cells for your immune system. The innate immune system cells recognize non-self, but they do not form a memory of a previous infection. The T cell line is also involved in response to infection, but the B cell line is your main memory cells. So next, I'd like to talk about the immune suppression that we use to protect a transplanted organ. So this is where we will get into all of the medications. On the screen now you can see there's a chart which describes the relative level of immune suppression that we target at the different phases around a transplant. So prior to transplant, we sometimes use what's called desensitization. These are the red area of the graph shown here. We use desensitization if a patient has identified a living donor that is compatible but maybe is not perfect. So this means that their immune system has previously been exposed to some of the donors, to things similar to the donor, and that there's an increased likelihood that the recipient might reject the donor organ. We use desensitization to proactively decrease the recipient's immune system to a point where the transplant would be safe. The next point in the graph would be the time of transplant. At the time of transplant, we use what's called induction immunosuppression, which is this very tall peak in the middle. Induction immunosuppression is the highest level of immunosuppression that we target, and like I said, it occurs at the time of transplant. So in the operating room, we often administer our first dose of immunosuppression, and that decreases the body's response to the donor organ so that it's not attacked immediately by the recipient's immune system. The next phase is the maintenance phase. After the induction period, we decrease the amount of immunosuppression that we're administering to our patients, and we maintain a moderate level of immune suppression, enough to protect the organ while not being so much that the recipient is having frequent infections or other complications from the immunosuppression. And then the purple peak is a treatment of rejection. Not every patient experiences rejection of the organ, but those who do will have another burst of immunosuppression to protect the organ and then return to maintenance immunosuppression. I'll next talk about the different medications that are used in these phases. I'll focus on the induction and the maintenance phases, and today I will not have time to discuss the desensitization or treatment of rejection specifically, although some agents are used during multiple phases. Our induction agents used at University of Virginia include rabbit antithymocyte globulin, or Thymo, and Basiliximab, or Simulect. These two medications both work on the T cell line. They prevent formation of T cells, which decreases the ability of the immune system to respond to the donor organ. The third type of medication that's used are corticosteroids. I'll discuss these a little bit more later, so right now we'll focus on Thymo and Simulect. The corticosteroids act on both the innate immune system as well as the T cells, and like I said, we'll discuss those a bit more later. So antithymocyte globulin is used for induction immunosuppression in our kidney and pancreas transplant patients. Certain liver transplant patients will also receive Thymo. Thymo can also be used as treatment for rejection. So if a patient has received their induction immunosuppression, is on maintenance immunosuppression, and then later experiences rejection of the organ, meaning that the body's immune system has recognized that it is non-self and has caused damage to it, we would then use antithymocyte globulin after the time of transplant to reduce the immune system's function enough to protect the organ. For the dosing of this medication, it's an IV infusion, and it's given at a dose of 1.5 milligrams per kilogram for at least 2 consecutive days. We can use it for many more than 2 days. In the case of induction immunosuppression, we usually use 2 to 4 days of treatment, but if rejection is occurring, we can use it beyond that point. For monitoring of this medication, we're looking at platelet counts and white blood cell counts. We're also monitoring for signs of infection. If you work in the IV room, you know that this medication is not made in advance. It's only on the trigger fill list. There are a couple of reasons for that. The first being these monitoring parameters. Platelet counts must be monitored daily, as well as white blood cell counts. If a drop in platelet count or white blood cell count occurs, then we have to reduce the dose. So we generally order this medication on a daily basis, and we don't schedule it in advance. The other reason that this medication is on the trigger fill list is the expense of the medication. It's approximately $900 per vial. They're 25 milligram vials. For your average patient, we're using maybe 6 vials per day. It's a very significant cost that's associated with each dose of this medication. Some other monitoring that pharmacists and nurses are doing while this medication is infusing would be for infusion reactions. These reactions can take the form of chills, rigors, or flushing, and they could also be an allergic reaction to the medication. We pre-medicate patients with Tylenol and Benadryl prior to the infusion, and we also give a steroid prior to the infusion to prevent these reactions from occurring. As I already mentioned, this is a trigger fill dispense only medication for the reasons we've talked about, and it is a do not tube medication, so it has to be walked to the floor. The other induction immunosuppression medication that we use at University of Virginia is Basiliximab, or Simulect. We use this medication in liver, heart, lung, and certain kidney transplant patients. This medication again is an IV infusion, and it's given as a 20 milligram dose on post-op day 0, day 1, or day 1, day 4, and day 7 in heart transplant patients only. For this medication, the main monitoring would be for signs of infection or for infusion reactions. An infusion reaction in this case would more likely be an allergic reaction to the medication. This medication again is extremely expensive. It's $4,300 per dose. Each dose is 20 milligrams, so it's 1 vial per dose. And so for that reason, it is also trigger fill only. This medication is also do not tube, as it is a monoclonal antibody. Next, I'll talk about the maintenance immunosuppression medications that we use. This, again, is occurring after the time of transplant, and this is the main phase that transplant patients live in. These medications are used chronically, generally, for the duration of the transplanted organ's life, but they are used at varying doses. I tried to show in this graph that the level of immunosuppression during the maintenance phase decreases over time. So the patient would not expect to be on the same dose of medication for the duration of the life of the organ. The medication classes that we'll be discussing next would include the calcineurin inhibitors, Tacrolimus and cyclosporin, antimetabolite medications, which includes azathioprine and mycophenolate, although we mostly use mycophenolate, so I'll focus on that. The mTOR inhibitors, everolimus and sirolimus, and corticosteroids, prednisone or methylprednisone. Final medication that can sometimes be used as a maintenance immunosuppression medication is belatacept. We don't have time to talk about that one today, but that is a medication that we often use for maintenance immunosuppression in our kidney transplant patients. So where do these medications work in terms of the immune system? So everything highlighted in red would act on the T cells. These would decrease the amount of T cell response that's allowed to happen to the donor organ. So Tacrolimus is the main medication that we use at University of Virginia. This is the medication that we would select immediately post-transplant and start patients on. If they're unable to tolerate it, we would then try other agents. This medication has many side effects, including high blood pressure, high blood sugar, tremor, headache, kidney disease, hair loss, and overgrowth of gums, and that's just to name a few. There are others as well. The dosage forms for this medication would be an IV infusion, and that's at University of Virginia, reserved for stem cell transplant patients only. We also have oral capsules which are given sublingual, so under the tongue. The capsule is actually opened and administered under the patient's tongue. An oral solution, and there are also extended release formulations, which we have one on formulary, and we have one which patients may use if they are involved in a study. For this medication, there's pretty extensive monitoring. We monitor trough levels, or the level of the medication immediately prior to the following dose in the patient's blood. And our goal trough levels immediately post-transplant are around 8 to 12 generally. And over time, we decrease that goal trough level as the patient gains more time since their transplant and has not experienced rejection. So over time, we're able to go from 8 to 12 as our goal, down to 5 to 8, and then down to 3 to 5. This is related in part to patient stability with their organs, so if they've not experienced rejection, we're able to do this, and we also do it to minimize the side effects of the medication. I mentioned that there are many side effects, and they can be very significant in the patient's lifestyle. This medication is also tricky because it has a number of drug interactions to be mindful of. So interactions that would increase the drug level of tacrolimus would include azole antifungals, so posaconazole, fluconazole, all of the antifungals in that category, warfarin, macrolide antibiotics, and grapefruit. These are all medications that a pharmacist would review and would monitor the drug level more closely, or may make a dose adjustment prior to starting the interacting medication. Medications that decrease the level of drug within the patient's body would include St. John's wort. Also, warfarin can have the effect of decreasing the drug level, and some epilepsy medications as well. There are also medications that increase the risk of kidney dysfunction in our patients. These would include NSAIDs. So at time of transplant, a transplant patient is instructed to never take ibuprofen, which is also known as Advil, or naproxen, also known as Aleve, ever again for as long as they are taking tacrolimus. Aminoglycoside antibiotics are also medications that can increase the risk of kidney dysfunction when patients are on tacrolimus. Sometimes it's unavoidable that we have to use an aminoglycoside antibiotic, so additional monitoring of the patient's kidney function and drug levels are important. Antiviral medications would also increase the risk of kidney dysfunction. Again, we would sometimes not be able to avoid these medications, so we would just have to monitor. The next medication in the calcineurin inhibitor class would be cyclosporin. I won't spend as long talking about this medication because, in a way, it's very similar to tacrolimus in its side effects and its monitoring, as well as its drug interactions. We don't use this medication quite as frequently, but it is an option if a patient is unable to tolerate tacrolimus. We'll sometimes switch to cyclosporin to try that medication. The dosage forms for this medication are only oral capsules and oral solution. So we don't have the IV and we don't have the extended release formulations that we do with tacrolimus. We're again monitoring trough levels, although the levels are different for this medication. They are higher. It's not a reflection of requiring more drug, but the level that's achieved is just detected differently within the body. So generally 150 to 250 would be a trough goal post-transplant, with lower levels being targeted over time. The drug interactions are very similar to tacrolimus. So those are, again, interactions that a pharmacist would be watching for and making adjustments as appropriate. All of the monitoring, drug interactions, and the potential for side effects are some of the reasons why you would see frequent dose adjustments with these medications. So this brings me to my next question. Tacrolimus and cyclosporin doses are frequently changed by the transplant team. Which of the following is not a reason that dose adjustments are made? A. The patient determines their own dose of tacrolimus and cyclosporin. B. Drug-drug and drug-food interactions can change the level of the medication in the body. Or C. Many side effects occur with these medications, so the dose is changed to manage side effects. And this answer is A. The patient does not determine their own dose. We again are extensively monitoring this medication and targeting very specific levels within the body. So drug-food interactions can change the level and require us to change the dose. And we do sometimes decrease our goal level to manage side effects of the medications. And when we change our goal level, we would also need to adjust our dose down. The next medication is Mycophenolate, or Cellcept. The other brand name for this would be Myfortic. This medication has side effects of decreased white blood cell counts, as well as upset stomach and diarrhea. This can sometimes be dose limiting, especially the white blood cell count, and it's a reason that we would frequently have to decrease the dose. The dosage forms for this medication are oral capsules in solution as well as an IV solution. Unlike tacrolimus, we can use the IV solution in our solid organ transplant patients. There are no drug levels to monitor, but there are a few drug interactions, although less severe interactions exist with this medication compared to tacrolimus and cyclosporin. These are more related to the absorption of the medication. So taking antacids or cholestyramine with the medication can decrease the amount of absorption from the stomach into the blood. The next group of medications would be our corticosteroids. These medications, if you've ever experienced a corticosteroid, maybe for an asthma flare or something like that, you might know that there are a number of side effects that come along with these medications, including increased appetite, high blood pressure, high blood sugar, stomach ulcers, mood swings, sodium and fluid retention, bone density loss, and cataracts. And again, that's just to name a few. There are many more possible side effects with corticosteroids. The dosage forms for this medication include oral tablets and solutions, as well as IV formulations. There are also topical formulations, although we wouldn't use a topical formulation in the case of transplant. With these medications, there are no drug levels to monitor and no major drug interactions to be aware of. So that's not a reason that we would need to adjust the dose. Generally, with the corticosteroids, we start with a very high dose and then we do what's called a taper. So on the day of transplant, we give 500 milligrams IV steroid in the OR, and then each day the dose is decreased until the dose reaches about 20 milligrams of prednisone daily. At that point, we'll generally stick with 20 milligrams, maybe 10 milligrams daily, and then decrease it from there. So a patient may remain on 20 milligrams daily for months, for years. It just depends on how they're doing post-transplant. Relative to the large dose given in the OR, 20 milligrams daily is not a very high dose, but it is enough to cause the side effects that I mentioned. So there is quite a bit of monitoring that must occur for these patients to control the side effects and prevent any stomach ulcers or very high blood sugars that could occur when using these medications. So my next question is related to the medication classes that we've described. Which of the following best describes how medications are used in transplant patients? A. The same medications are used throughout the patient's post-transplant course. B. Medications are only used after transplant to care for the transplanted organ. Or C. Medication doses and the medications used change throughout the post-transplant course. The answer to this question is C. The medication doses and the medications used change throughout the patient's post-transplant course. We've talked about this a little bit so far. So the trough levels might change. Over time, we do try to limit the amount of immunosuppression that the patient's receiving because of the many side effects that we've talked about. The answer to the first answer is incorrect because of the reasons that I've just discussed. We don't need to use the same medications throughout, and we use different medications during different periods. So we discussed the desensitization period, the induction period, the maintenance period, and then the rejection period. We focused on the induction and the maintenance period, and at those time points, we would use different medications and at varying doses. The answer B is incorrect because, as we discussed early in the lecture, medications are not only used after transplant. We sometimes use medications prior to transplant to do what we call desensitization, to optimize the patient's chance of not experiencing rejection when they get the donor organ. So with all of those side effects that I've discussed, there are a number of other medications that you would expect these patients to be receiving as well. We call these our supportive care medications. This can include blood pressure control medications, stress ulcer prophylaxis medications, which would be those medications that reduce stomach acid, so for example Pepcid or Protonix. We use aspirin for prevention of blood clots from forming within the blood vessels where the donor organ was connected to the recipient's blood vessels. Pain management, especially in the post-operative period, bowel regimens, and blood glucose control. Discuss multiple classes of medications that are used post-transplant to control a patient's blood sugar. And then finally, we also use prevention of infection post-transplant because these patients with decreased level of immune function are more susceptible to developing infections. So patients are recommended to be up to date with all of their vaccines, but we also use antibiotics, antivirals, and antifungals to prevent infections from occurring. We generally use the medications listed here, one from each class, and this is used for up to a year post-transplant as a standard protocol. Sometimes we have to extend the use of these medications beyond that time point if a patient has experienced an infection. So this brings me to the end of the presentation today. We've discussed the induction agents as well as the maintenance immunosuppression agents for solid organ transplant patients. I want to thank you for your time and your attention, and please feel free to reach out with any questions.